Thank you so much, Dr. Sari, Dr. Chiello, for this invitation. I'm really honored to be in this historical institution where a lot of cardiology and cardiac surgery history was made. And here, okay, so in the next 30 minutes, I'll focus on intramural PVCs and VTs, which is an argument that I'm quite passionate about because it's, of course, it's a complex topic for us, mostly for both for mapping, but also for ablation. So what are the diagnostic criteria for intramural ventricular arrhythmias? Of course, we could use some surrogate criteria from activation mapping, because for many years, we've been limited by mapping just the accessible surface of the endocardium or the epicardium. So anything that is intramural, we don't really see it directly. We'll talk about that later. But essentially, when we have a broad area of early activity in both sides of the septum, for example, we can guesstimate that there's something intramural going on. Whenever we do see far-field electrograms that are early in an area of earliest activation, we can suspect that it is something intramurally of origin. When, of course, there is absence of QS unipolar electrograms at the earliest site, whenever you map, you have an R wave in the unipolar electrogram, then you can suspect there is something deeper going on. And of course, when we're talking about VTs, mostly reentrant VT, you have manifest entrainment in the best activation sites that you can access. Pace mapping, of course, is suboptimal because for this intramural origin, just like having something originating deep in the septum, for example, you will have cancellation of forces on the right side and left side of the septum. So you cannot directly pace from there unless you can access with a small catheter, and we'll talk about later from venous perforators. But typically, you have suboptimal pace maps from the endocardium as well as the epicardium. And of course, the easiest is to ablate at the earliest area, and you have no effect of a late termination effect or a shift in the QRS axis. And then you can definitely suspect that you're dealing with something intramural. There was a paper done by Frank Bogon group, and I think it was actually quite clever. It was a reconstruction of the QRS morphology with pace maps done with MATLAB. And this software really never got into production for clinical use. But essentially, it was quite clever. They basically paced from multiple sites in an area of broad activation. And they averaged the QRS on a 12-lead EKG. And if that average QRS that was reconstructed on MATLAB approximated the QRS morphology of the PVC, you can suspect an intramural origin, which is quite clever, I think, but it's, again, is not available for clinical use. For patients with cardiomyopathy, septal substrate, intramural substrate is really important. There was an updated series from University of Pennsylvania where up to 20% patients have septal involvement with VT, 11% with isolated only septal involvement. 29% of these have intramural abnormalities that can be detected on MRIs. And typically, you have multiple VT morphologies with exit on the top of the septum and the bottom of the septum. But typically, again, you don't target the exit site for these VTs. You need to find the isthmus, which is, again, protected intramurally, and it becomes quite complicated to detect and to eliminate. So most commonly, we're talking about this area up here, which is the upper septum. And you can see here is a quite complex area. This is a modified aerial projection of the heart. And you see the right coronary cusp on one side, the posterior RVOT, and intramural arrhythmias from the upper septum originate from this liver tissue here. You have an example here of a PVC with a good pace map from the posterior RVOT. And of course, intracardiac echo in this case is quite helpful, because you can see your catheter producing contact with the posterior part of the RVOT underneath the pulmonic valve here, this is the right pulmonic cusp. And here you see on the opposite side, between the right and the left coronary cusp here, right-left junction, essentially. So you know you're posterior on that side. You have an early activation here. And in general, anything that is earlier than 30 milliseconds, usually you're able to make an effect in terms of the ablation with success. So now, when we look at intracardiac echo, you really realize that there is a lot going on in that location. Here you can see an intracardiac echo, the same one that I showed you before. It just flipped the other way around, because that's the way I still look at it, because there's a University of Pennsylvania approach for echo. But essentially, you see the pulmonic artery here. You see the RVOT in this side, the right pulmonic cusp and the anterior pulmonic cusp here. And you see here the right coronary cusp and the left coronary cusp up here. So the tissue that you're targeting is really this tissue here, which is the between the posterior RVOT and the coronary cusp region. So now, when you do have a PVC that looks like that, so it's a left bundle PVC with relatively early transition, you know that it will deal with a septal site of origin and posterior because lead 1 is positive. Now, when you're mapping this PVC, you know that you will need to map different areas just looking at the intracardiac echo. You will need to map the posterior alveoli underneath the pulmonic cusp. At the level of the pulmonic cusp, or even higher here, you can then chase the opposite side from the right-left junction, from the right side of the coronary cusp, or from the left side of the coronary cusp. So only after you sampled all these areas with activation mapping, you can come up with an ablation strategy. And again, this is all related to what we see on intracardiac echo when we're actually mapping these arrhythmias. One important phenomenon that we observe when we deal with intramural arrhythmias, we do target the earliest activation site. We have suppression of the PVC, and during the waiting phase, the PVC comes back with the same coupling interval, but with a different morphology. This suggests that it's the same focus, that is just shifting axis in a different site. And this happens because this has been described also by Neil Kay's group. There is preferential conduction in the outflow tract region. So some arrhythmias may be intramural with earliest activation of one side of the septum. As soon as you ablate that side, it's going to exit on the opposite side. And this is something that we looked at. This was a series of cases that we put together. Again, these are cases of intramural arrhythmias. When we ablate, we have termination with ablation. 10 minutes or 20 minutes later, we have up to 20 minutes waiting period in the paper. We have recurrence with the same coupling interval and a different morphology. You can see lead 1 here goes from positive to negative. And again, it's the same focus, we think, with different exit sites. This phenomenon happened in 4%, so 17 out of 446 patients that we studied. The QRS shifts after ablation. And remapping in this case was very important because ablation at the same site very rarely was effective to eliminate the second PVC. So remapping helped because we found a new area of early activity in a different anatomical site in 73% of cases. This is just an example. The first PVC was ablated and it was earlier within the distal coronary sinus. So here we're talking about LV summit really, but still intramural. And you have recurrence with a shift in QRS morphology. It becomes more right bundle and more lateral. And then remapping showed a second early site underneath the coronary cusp region. So again, whenever you see a shift in morphology, instead of reapplying in the same site, which is quite intuitive, remapping always helps in these particular cases. It doesn't take too long. Of course, up to a few years ago, we didn't know what was happening in the intramural space, and now we do know if we can access the intramural space with septal perforators. You can use the arterial branches. Of course, it's complicated, and for us, we're much more familiar with the venous branches. And here, I have to say, this technique, although it's been is used by me and others and quite extensively, it's limited by the fact that, of course, the anatomy of the venous perforators is very variable in between patients. So you can only access the perforators that will get there. And the second aspect is that the septal perforators amenable for mapping are only available in the AIV area, so in the upper septum. In the middle cardiac vein, if you do an occlusive venogram, you do not see perforators that you can access with mapping catheters, not even with wires. So that's a limitation for the inferior septum. But in general, the way we work with this is quite intuitive. We advance a sheath. Typically, we like to use a steerable sheath, but it's not necessarily. We do have distal venogram here. We select the target vessel from the AIV, the septal perforator. The best view for this is really the LAO caudal, but you can also work in the RAO projection if you want. And here you access the septal perforator with a macro catheter. Typically, we use a Terumo catheter, a glide catheter for French, and then we deliver either insulated wires or small French multipolar catheters in that location. So the benefit of that is that we have been helpful to identify cases where there was early activity, even earlier activity in the intramural space that we were completely missing with just by mapping the surface of the endocardium and the epicardium. This is just an example of here you see a coronary sinus access with an Agilis sheath, which is a defectable sheath. There is a multipolar catheter in the anterior interventricular vein. There is a septal perforator mapped with an insulated guide wire. And you can see that on the guide wire, you have very early activity during this PVC morphology. So this was the sinus rhythm. This is the PVC here, earlier than anywhere else. Now, you cannot ablate from the guide wire, nor you can ablate from a multipolar catheter in that location. So for these procedures, 80% of the times, you can get the job done by ablating the closest anatomical site that you can access with your ablation catheter. So you do use something that we call an anatomical approach. So essentially, you deploy your ablation catheter at a site that is as close as possible to the guide wire. Here you see an REO projection and LEO projection, and ablation at that site is able to eliminate the PVC. You see here there is a reconstruction. And to be honest, also, most of the times this corresponds to the earliest breakout in the LV endo. But again, before we ablate the earliest breakout, we always want to map the intramural space. And you see here, we're ablating here, we're creating a lesion, and the PVC gets eliminated. Now, this is called an anatomical ablation approach, and this is just an example, another example here, where we use a different mapping system with impedance space. And the benefit of this is that you can really reconstruct the anatomy of the coronary vessels with any catheter on any wire that you like. And here you see that is a coronary sinus, the great cardiac vein, the anterior vein, and the septal perforator. And again, very early here. Here, in this case, we use a multipolar catheter, 2.5 French here, deployed in the septal perforator. And the benefit of these catheters is that the electrodes are actually echogenic. You can actually see it on intracardiac echo. And as you can appreciate in these pictures here, sorry, let me go back here. Right, this one only. You can see the catheter that is deployed within the septal perforator. You can also estimate the closest distance that you have to the LV endocardium versus the RV endocardium. And in this case, you can see that the LVOT is much closer to the septal perforator branch here compared to the RVOT. And that's how we choose which area to target anatomically. And in this case, that's exactly what we did. There was an ablation done with an ablation catheter here deployed within the LVOT here. We're ablating right opposite to the area of early activity intramural space, and we're able to eliminate the PVC. Again, 80% of the times we're able to eliminate this. Actually, when we looked at this aspect of anatomical ablation, so in other words, you have an early activation somewhere, either epicardial or somewhere intramural, and we ablate anatomically. If you also plot into this group of patients, the epicardial ones, the success rate of an anatomical approach is only 50%. So you can only successfully eliminate PVCs from an anatomical adjacent site in about 50% of cases. It's just a series of patients where we have early activity in the AIV or a branch of the AIV, and we couldn't ablate in that location because it either proximity to the coronary arteries or inability to advance the ablation catheter in that location. So we ablated from the opposite side. And the only predictor of success was the anatomical distance from the target site to the adjacent site. It has to be ideally less than 10 millimeters. When we ran the ROC analysis, it was less than 12.8 millimeters. But most patients, again, were within 1 centimeter from the earliest site. And again, the success rate with this, when you also include the epicardial cases, was about 50%. Switching gears now to the inferior septum. Of course, the inferior septum is even more complicated because there is no epicardial portion in the inferior septum because the inferior septal left ventricle curls up towards the right atrium here in an area that is called the posterior superior process of the left ventricle. And this happens in humans because the plane of the tricuspid annulus is more apically displaced compared to the plane of the mitral annulus. And therefore, you have a portion of the LV septum that is in direct contact with the right atrium. That's why you can have pathways, for example, that inserts from the right atrium to the left ventricle just because of this anatomical feature of the human heart. And here you can see typically the displacement is 0.5 to 1 centimeter anteriorly. So there is a lot of tissue of the left ventricle that is in contact with the right atrium directly, that is outside the coronary sinus. This area can be targeted for access of the left ventricle in patients with those two mechanical valves, and can also be targeted for pacing, for example. And there are some, I think, some innovation that is coming up using this area for septal pacing and so on. Again, this is a very complex area, but it's something that you can use for multi-purpose, I would say, multiple, I would say, applications. So the posterior superior process of the left ventricle is a promontory. So it's, in other words, it's like a triangular space that is located, bounded by the septal leaflet of the tricuspid annulus and the mitral annulus here, the ostium of the left ventricle, and the non-coronary cusp on the most cranial side. Why is that important? Because in some cases of inferior septal PVCs, you cannot directly eliminate them with an intramural from the LV side. And this is just an example that we learned years ago. This was a case they looked like left septal PVC, inferoseptal PVC, or mid-septal PVCs. And here, the earliest activity that we found was right underneath the non-coronary cusp in this area of the left ventricle here, that you can see where the eyes is located. The ablation catheter is actually touching the inferior septum of the left ventricle. In this location, we only had late suppression of the PVC with recurrence. So therefore, we were trying to understand how to target the opposite side, We know from the Elvis summit, the opposite to the endocardium will be the epicardium. For here, the opposite will be, by definition, this area here, which if you look at intracardiac echo, is the right atrium. And again, this is the portion of the posterior superior process of the ventricle that is in direct contact and adjacent to the left, to the right atrium. So the first cases we did in this was with cryoablation, just because we didn't know how close we were to the conduction system. But again, we were able to successfully eliminate these PVCs with cryoablation. And as soon as you go to -35 to -70, we have complete suppression of the PVCs. So again, the opposite of the left ventricle in the inferior septum will be the right atrial side. So be mindful of that for inferior septal PVCs. There's just another example here. You can see the catheter is deployed within the right atrium and is touching directly the posterior aspect of the septum of the left ventricle. And again, this area is the same one that we target for some pathways that inserts from the right atrium through the left ventricle. For some PVCs, some VTs can be eliminated from here, but also you can use it as an access site for a patient with dual mechanical valves from the right atrium to the left ventricle in the aortic and mitral position, because again, this is an area that you can chase and target for that. Finally, few more points about mid-septal PVCs. Of course, these are is another important areas, and these are so-called the parahisian PVCs. Now, if you look at the papers for parahisian PVCs, the definitions are really different in different papers. Some papers say within 1 centimeter. That to me is a little bit too generous from the His cloud. For me, a true parahisian PVC, whenever you have a Purkinje potential preceding every single QRS in sinus rhythm and the earliest activity during PVC. Now, there is a problem with parahisian because there is no such a thing as a parahisian PVC because the His is an atrial structure. And we, of course, I'm not an expert of that, but here there are a lot of experts of conduction system pacing. They know that the His is actually in the atrium. And as soon as the perforating bundle of His reaches the myocardium, it bifurcates in the right bundle, which is a true bundle, and the left bundle, which is more like a waterfall. There is not really a single bundle. There are more than one, many fascicles that go down that way. But the implication for that is that, sorry, that all the cases of heart block that we have been reported for parahisian PVC ablation are because of bad, in my opinion, poor technique with catheter mapping and ablation. I will discuss this in a second. Essentially, the tissue that we are targeting here is the tissue between the septal leaflet of the tricuspid annulus and the septum here. The His will be much more proximal to that in the atrial side. So why is that important? If you ablate a parahisian PVC with a direct approach like this, the tricuspid annulus will shift anterior and posterior by about 1 to 1.5 centimeters, because you know that from echo, from TAPSI, it's called the tricuspid annular motion with systole. And every systolic beat, the ablation catheter will shift backwards to the atrium. And that causes injury to the conduction system. And because every time you lose contact with the myocardium, you go back to the atrium, you may injure the His. So the best approach and the safest approach for this is to actually loop your catheter. Let me show you first here. Correct this, okay? Loop your catheter underneath the septal leaflet of the tricuspid annulus. By doing that, and I go back here, you will be in this location here, and you are protected from atrial shifting by the septal leaflet to the tricuspid annulus. So in this case, you will record Purkinje potentials with a far field A, but that's a proximal right bundle potential. So the true parahisian PVCs that coming from this myocardium here can be associated with right bundle branch block, but very rarely, I've not seen it with that technique really, can be associated with complete heart block, because you can't really reach the septal perforator, the perforating bundle of His with that type of approach. If you go with a direct mapping and ablation approach, that's dangerous because of the systolic motion of tricuspid annulus and the posterior shift of the catheter. So typically these PVCs that are left bundle morphology, they tend to have a QS in V1, very similar to what we see with parahisian pathways, for example. The precordial transition can be variable, but typically it's between V3 and V4 in most cases, from the right side, or V2 and V3 from the left side. Typically, you have a monophasic R wave in lead 1, positive in ABL, and they tend to have, of course, a narrow QRS because they're septal origin. Again, this is just an example here. This is the area that we want to target. If you go with your catheter straight here, with a straight approach, without looping it backwards and protecting your catheter by the septal leaflet, you have risk of injuring the conduction system because of the posterior shift of the catheter with both respiration and systolic motion. Here you see, in this location, typically you do see, we call it a HIS, but really this is a proximal right bundle potential. There is no A here. So in this case, with ablation at this site, you may end up with a right bundle bench block, which is, I guess, arguably a complication of the procedure, but it's an acceptable complication compared to heart block. Again, whenever you're mapping, though, a Parisian PVC, always be mindful of this anatomical proximity of different areas. They are either the annulus, a little bit more anterior to the annulus, or the opposite side on the right coronary cusp, or the junction between the right and the non-coronary cusp. Always map those adjacent points. But the true Parisian PVCs that we call, or peri-right bundle PVCs, they really originate around the area of the right bundle branch, and here very early in the RP side. And again, the best approach, and we can discuss later, is the looping the catheter backwards and protecting your tibial catheter by the septal leaflet of tricuspid annulus. How do you achieve that? Typically, you need a deflectable sheath here. We like to use a large curl sheath, deflecting down to overcome the issue with the eustachian ridge, and then looping the catheter backwards here in the Parisian location. And here you can see on intracardiac echo that the septal leaflet is protecting your tibial catheter here from shifting backwards, because everything will be moved with the septal leaflet anterior and posterior without going to the atrial side. Few more points about bailout ablation approaches. Different techniques have been described. Prolonged unipolar RF, you can prolong it up to 3 to 5 minutes. Really, animal studies show that for RF, you have a plateau at roughly 3 minutes, although in some human studies with there's some data from MRIs and SCAR, you can prolong it up to 5 minutes in some cases, although again, the jury is still out to really how much you need for a radio frequency. You can lower your ionic irrigant with half normal saline or D5W. We'll talk about that in a second. You can use alcohol ablation for septal perforators when you can access that. Bipolar RF ablation, so from a distal electrode of 2 ablation catheters with a single generator. Or you can use simultaneous unipolar radiofrequency ablation with 2 separate generators and 2 different catheters. We'll go through this very quickly in a second. And finally, there is some unknowns about the new technologies like pulse field ablation. So prolonged RF may work. This was a series, again, put my colleague Sanjay Dixit from Penn here, when they looked at 443 patients for PVC ablation. And it seemed like when you failed at 60 seconds of radiofrequency in one specific location, so you have a late suppression, let's say at 30 to 40 seconds, and you prolong to 60 seconds, and then you stop, patients tend to come back more often with PVCs in the waiting phase. If you prolong it up to 120 seconds, and so 2 minutes to 3 minutes, tend to have higher success. Again, this, I think, needs to be corroborated also by some animal studies, more animal studies, I think, because we don't really understand how the lesion grows after 3 minutes, really. It's never been tested. And so we don't clearly know how safe is that and how effective that is. This is still something that I think it puzzles me a little bit, the use of a lower ionic irrigant, half normal saline, for example, D5W. Half normal saline is the one that is mostly used. There was a series of patients with a multi-center study where they looked at the ablation success. When you fail with normal saline, you switch to half normal saline and you have a higher success rate. Now, half normal saline only makes sense when you fail at 50 watts with normal saline, because that means you need more power than that. But if you look at the methods of this paper, they really used powers that have anywhere between 30 watts and 45 watts. So it's not really clear to me how half normal saline would add benefit compared to a normal saline lesion at 50 watts. But the idea here is that if you have a lower ionic irrigation around, you basically shunt the current because of the higher impedance of your irrigation around your electrode towards the myocardium. So you have essentially higher power that is delivered at the epicardium interface, at a myocardial interface. A few words about the benefit of bipolar ablation versus simultaneous unipolar. And this is just my opinion. I think in the septal region, specifically when you're targeting epi to endo, or from the coronary sinus to the endocardium, or from the cusp to the endocardium, if there is an impedance mismatch between the 2 ablation catheters, simultaneous unipolar is more effective. The reason being is because bipolar is less effective whenever there is an impedance mismatch between the 2 catheters, because any bipolar RF application will be shunted to the lower impedance system, so visually becomes like a unipolar lesion. If you have the same impedance, so you're bleeding from one side of the septum to the other side of the septum, bipolar is more effective than simultaneous unipolar. But if the impedance is different, it's better that you work with simultaneous unipolar. You can monitor the impedance trend in both generators, and we can probably talk about this a little bit in the discussion. Ethanol ablation has been pioneered by Miguel Valderrabano and has been incorporated now by many of us, actually. And the problem with this is, of course, you need to be lucky enough to access a septal perforator that will be feeding the area of interest. And the second important aspect is that the lesion that you create is not always controllable. Even if you protect the septal perforator with 2 balloons, sometimes it's hard to achieve a lesion that you can actually control, like we do with the radio frequency or other techniques. But there is no question that whenever you have an intramural PVC that is early in a septal perforator and earlier than anywhere else, that alcohol ablation in that site works. Finally, a few words about pulse field ablation. We've been interested in looking at this in our animal lab at the Cleveland Clinic. And this is a study that we just submitted for publication. And here was actually a very simple design. We started using in RF versus pulse field ablation in common areas that are commonly targeted for PVC. So we use the LV septum, the papillary muscle, the LV summit from the coronary sinus, and the epicardium. And what we found here is that pulse field ablation was consistently better than radiofrequency in terms of the lesion depth on the papillary muscle, on the LV summit from the distal coronary sinus, and on the epicardium. In particular, in the LV summit area, we were not able to see any lesion at all with radiofrequency in about 30% of cases, which is, again, not surprising, but it's something interesting. And the radiofrequency here, we also randomized them to alpha-normal saline versus normal saline. And again, we found no difference in terms of the lesion size. Again, that's why I think we need to still study a little bit more the benefit of alpha-normal saline in that location. In terms of the safety effects here and safety endpoints, in the endocardium, both strategies were similar in terms of depth. That was interesting also finding on the septum, but also in terms of safety. Stim pops were almost universally seen only with radiofrequency. Proarrhythmia was more common with radiofrequency, again, compared to pulse field ablation. What we did find that it was unique to pulse field ablation was ST segment elevation in the epicardium. There were 2 different types of ST segment elevation, one related to spasm. Those were because we were close within 5 millimeters from the coronary arteries and was proven by coronary angiogram. The second type of ST segment elevation was very diffuse. And it was not related to spasm, again, because we showed the coronary angiogram, there was no evidence of macroscopic spasm. And again, there may be some ionic changes in the epicardium whenever you ablate with pulse field ablation that cause this diffuse ST segment elevation that looks like really a localized, well, more than localized, but a diffuse Brugada type of pattern. There is J-point elevation and rounding in those locations. We showed the coronary angiogram. We didn't find any significant coronary narrowing or spasm, and also histology didn't find any evidence of that. And the other aspect of it is that we're looking at intracardiac echo. In those cases, we didn't find any evidence of wall motion abnormality. So again, suggesting that it's nothing to do, or maybe not much to do with the coronary arteries. I think I'm going to stop here and open this for discussion. Thank you for your attention.